Visit doctors, and they'd be ill and unwell, and you know, it'd take a long time before they could actually assess and determine what was the cause of the illness. So to the Southern Europeans, people of African descent, people from the Middle East, South Asians, Hispanics, I have large numbers of those communities in my electorate. I see it as a responsibility as a member of parliament to ensure that I do whatever I can to assist in raising awareness, encouraging people to be tested, but more importantly, to also ensure that health authorities, that hospitals and doctors also are aware of sickle cell disease, and also encourage patients or people that they come into contact with who aren't well to think about, it's all about thinking about putting this issue on the table, and that's what awareness is about. So to actually consider the possibilities that you should be tested for sickle cell disease. As I said, look, I think research is really important, and we all know, and there are some doctors amongst you, both here and overseas, that the research dollar is competitive, and people have to fight for money to do research. That's why awareness is very important, and the community, and I've seen communities come together to fight for their right to have research dollars spent on conditions and diseases, in this instance sickle cell, that affect them. So I feel that Australia has always been at the forefront of research in many medical medical research as such, but I know for years we have done quite a bit of work in thalassemia, and I've been involved with thalassemia associations for quite a large number, for many years. I know how important community involvement and advocacy is, not just to awareness, to raising awareness, but also to ensuring that governments respond and accordingly, and provide the sorts of funds that medical researchers and doctors need. So I would be very, very happy to continue in ensuring that sickle cell disease here in Australia is recognised as a condition that is that is prevalent amongst large numbers of our migrant communities, and with the increase of Australians from African communities, I think we have to acknowledge that we need to turn our attention to this valuable research that assists people to be able to manage their lives living with sickle cell. And I know, Agnes, I've heard your daughter's story, and I heard it last year, and I'm really pleased that you've referred to her as being cured. These are the sorts of results that we want to get, because ultimately communities deserve to be looked after, not only by their politicians, not only by their medical profession, but the medical profession deserves to be helped financially to research and to look for solutions and for cures. And of course, I'll just finish up by saying, all of us, we're doing this during a COVID-19 period. Research and racing for a vaccine and a cure is foremost in the minds of not just scientists and doctors and politicians, but the broader community. And we've seen the communities realize that in order to resolve diseases that are a threat to the community, you need to rely on the excellent work of your medical and scientific community. And now is a good time to be promoting this sort of advocacy, and to be talking to each other both here and internationally, and seeing how we can as a network. And tonight, this is a great network. We can network to help each other go forward in the awareness raising and the management and the seeking of a cure to sickle cell disease. Thank you. God, I hope you heard all that, because I can't repeat it. I'm not getting any response.
Yes, we did.
Okay,
Thank you. Thank you very much. You're on mute, Dr. Greenway.
Thank you very much. Yes,
thank you very much. Very
No
good.
worries. I just want to know that someone's out there on that side.
Yes, very excellent.
Yeah.
Right.
Yeah. Thank you very much, Honorable Van Vakina. At this point, I know there's a few people that are still waiting for. We will bring in Professor Joy Ho to give her presentation, please. Thank you.
So I've just shared my screen. I probably will just use the slide format like this because I gather sometimes it doesn't work very well if I do the projection screen. So hopefully this will work. So I'm going to talk about sickle cell disease in the adult. I was given 10 minutes and I hope I'll keep to time. I would just say that, first of all, that there are estimated to be about 50 million heterozygous sickle individuals in the world. And this really emphasizes the importance that I think yesterday and today that Agnes has been trying to emphasize the importance of testing, for instance, of prospective parents, given that as Australia increases our intake of migrants from various communities in which sickle cell prevalence is high, that we really need to get the word out to enable people to be aware of this and to have appropriate testing. So just a number of figures that are derived, some from a publication a bit earlier, but nevertheless is still very relevant to the scale of the problem. So in Africa, there are about 200 to 300,000 sickle cell disease newborns per year, but significant initiatives have been made in recent years in newborn screening. And I work on the International Committee in the American Society of Hematology, and even ASH, which is the American Society, is actually doing a lot of work and assisting in that area. In the US, there are 60 to 70,000 sickle cell disease patients, and there's one newborn per 600 births in the Afro-American population. In France, it is estimated about 10,000. Now, in Australia, however, there are no definitive data. And through the efforts of Dr. Anthea Greenaway and Dr. Kylie Mason, who really in the last few years have taken a lead in bringing people together to look at sickle cell disease. At a meeting last year, just in terms of a very general estimate, we think there are about 1,000 sickle cell disease patients, and that is certainly increasing, as I said, with the immigration patterns. But this lack of definitive data really reiterates the importance of how that we need more research, and as a result, a new registry has recently opened, and the word new should be in inverted commas, in that we have had a hemoglobinopathy registry for which I am actually chair of the steering committee since the early 2000, around 2011. And the difficulty there is that we haven't really been able to get it off the ground very well. We've collected a large number of thalassemia patients, but in recent months and in the past year, there's been an increased initiative, an impetus to collect data on sickle cell disease, and we will welcome any continued support to achieve more granular and better data on the state of play in our country. So as far as distribution of sickle cell disease, here are the main groups in the Afro-Caribbean communities from the Mediterranean, and this in the earlier days, most of our patients were from Italy and Greece, also in India, and also we have now an increased Middle Eastern population. And interestingly, it has the same relationship with the distribution of malaria historically as thalassemia. And I don't have time, as I only have 10 minutes. I won't go into the mechanisms or scientific mechanisms of that, but more than happy to chat. Now, most of you will know this, but I'll quickly say, so sickle cell disease is due to a mutation in the beta globin gene in a specific molecule specific. So the globin is the protein molecule in a specific amino acid, which is called number 6. As a result of this mutation, the sickle hemoglobin, that protein, undergoes crystal formation when it becomes deoxygenated, when there's less oxygen, and aggregates into and arrange into rod-like fibers. As a result, it leads the red cell to deform. And in addition to that, there is also loss of the membrane of the red cell and changes in the ability, changes in the permeability of the red cell membrane, leading to irreversibly sickled cells. This audience knows all about it, but my non-hematological colleagues, for instance, are always very interested in the fact that they have such an unusual conformation. And one can imagine in the old days when people look down the microscope when the disease was first found, that they saw these literally red cells in the shape of sickles. I won't go through the rest of the mechanisms in detail, but just to say that various channels that of potassium and water loss are affected, leading to dehydration of the red cells. There's an abnormal adhesion of the sickle cells, not only to themselves and to white blood cells, but also to the endothelium, which is the lining of the blood vessels. This leads the red cells to become more fragile and break up and therefore cause a chronic anemia. And the rigid cells in forming aggregates, one of the major problems is that it leads to blockage of small blood vessels and therefore leading to infarction of major organs. I'll very briefly skip through this next slide. It summarizes some of those scientific mechanisms, but just to mention, for instance, that it does not only affect red blood cells, it also affects platelets, which are the cells in the blood that normally cause clotting, and they're activated, and sickle cell patients have an increased tendency to clot. It affects the lining of the blood vessels called endothelium. The fact that the blockage of blood vessels leads to low oxygen as the tissues become more reoxygenated, meaning there's more oxygen, that in itself can set up inflammation and cause harm. And an important aspect is that the process of hemolysis, which is red blood cells breaking up, leads to reduction of nitric oxide. And this is a molecule which I, again, won't go through the very specific biochemical mechanisms, but the main thing is that the lack of this molecule called nitric oxide, because nitric oxide is a vasodilator, meaning it dilates blood vessels, the lack of it leads to a number of conditions like pulmonary hypertension, which is like having high blood pressure, but that blood pressure is in the lung, and that can in turn affect the heart. It can lead to strokes in the brain and lead to ulceration, for instance, in the legs. Interestingly, and consistent with the way that the disease is caused, the mechanism, is that there are a number of factors which make the disease, that can make this disease more severe. For instance, the level of oxygen in the red blood cells is very important, because the lower the oxygen, the more the red cells sickle. The level of hemoglobin, that is that protein concentration, the protein that is abnormal, can also increase. The higher the level, because of the increase of viscosity, that is the thickness of the blood, can increase sickling. And thirdly, what is very, very important to understand is that there is a form of this hemoglobin, which is the molecule that is affected in sickle cell disease, in the development of an individual. In the fetal stage, there is a particular form which disappears in the adult. But if you can maintain high levels of this fetal hemoglobin, this fetal form of the hemoglobin can inhibit the polymerization or the aggregation of those sickle cells, of those sickle fibers to form sickle cells. So here are, in brief, the manifestations, which I will just list. I already said the red cells break up, and therefore you get chronic anemia. In children, there is this hand and foot syndrome with inflammation of the finger, of the hand and feet, and we talked about it actually last night. in the Red Cell Symposium. There's also painful crisis, which is one of the most important manifestations, where the blockage of blood vessels leads to infarction of bone, leading to generalized pain. Brain syndrome, where there are blockages in the brain leading to stroke-like syndrome, sometimes to permanent neurological damage, even in children. In the lung syndrome, where we can have infarction of the lung tissue leading to shortness of breath, or otherwise called dyspnea, chest pain. Priapism, which affects the penis, which can be a very distressing symptom. In certain situations, such as contracting a particular virus called parvovirus, this can lead to aplasia, meaning that the bone marrow doesn't produce, markedly decreases in its production of various blood cells. And there's also sequestration, which is a way in which the spleen traps the red blood cells, and suddenly the red blood cells level completely drops down the bottom. Then the more long-term effects include avascular necrosis, which is a term which we use for the effect on bones, especially in the hip joint and the shoulder joints, where the heads of those long bones die, and therefore cause chronic issues, particularly of the hip, infection, particularly of bone, called osteomyelitis, and also the effects on kidney, which can lead to kidney damage. I've already mentioned the lung hypertension, and ulcers, and also gallstones, and also proliferation of the red blood, of the blood vessels in the eye can lead to significant damage to the retina of the eyes. So I'll now talk about management in brief. So first of all, some supportive management. Of course, we avoid precipitating factors, which include low oxygen infections and dehydration, because the patient can have repeated infarction of the spleen, and we call that hyposplenic, because the spleen is really the garbage tin or the filter of the body for various infections. Patients would therefore be susceptible to infections like pneumococcus for pneumonia, meningitis with meningococcus, and Haemophilus, as well as malaria. And therefore it's important to administer appropriate vaccines. We treat the crisis by treating the precipitant, which can often be infection. Sometimes there is no particular precipitant, with intravenous fluids, oxygen, pain relief, and sometimes we need to transfuse. With the lung crises, people may have to be admitted to intensive care and may need exchange transfusion, which we again spoke about last night, where we take away blood and give back, take away the affected blood with sickle cells and give back donor blood. For surgery, we often have to provide, as particularly more severe surgery, we have to perform an exchange transfusion before then. And now I will talk about the drugs. So first of all, the anti-sickling agents, one of which is hydroxyurea, which should now really be considered the mainstay of treatment for sickle cells. The main way in which it works is that it increases that hemoglobin that occurs in fetus, called fetal hemoglobin, which reduces sickling, but it also reduces white blood cells, leading to reduced sticking of the sickle cells to white blood cells and the reduced blockages in that sense. So here we have fetal hemoglobin induction. The mainstay of that is hydroxyurea, although there are other less commonly used drugs, such as L-glutamine, which is a short chain fatty acid. And indeed, hydroxyurea and to a much lesser extent used the L-glutamine are the only FDA approved treatments for sickle cell disease until a few years ago. And I should really change this slide, because there are two others which are now approved, and you can see that under newer agents, crizanlizumab and foxalotor, and I'll talk about that in a minute. Where I put P-selectin, it should be P-selectin for the crizanlizumab. Of course, I'll briefly speak about red cell transfusions, and I have already told Anthea I won't talk about transplants, because due to the increased effectiveness of transplants in children, it is predominantly still a pediatric procedure. So the effect of hydroxyurea is summarized on this slide. It increases fetal hemoglobin, as I said. It reduces pain crises, high hospitalization, transfusions, decreases mortality, and decreases neurological events, although it is felt that this is an early study, that there is insufficient kind of evidence to say that it definitively does that in adults. There is low level evidence in children. So many people like myself, when we deal with a brain syndrome, we would still choose to use transfusion to prevent recurrence rather than just hydroxyurea. And here are the indications for transfusion, including multiple crises, stroke, chest syndrome, severe hemolytic anemia, aplastic crises, for the long-term management of chronic pain, when patients have not responded to hydroxyurea, repeated painful crises, splenic sequestration, that very drastic effect in children, and maybe Anthea will talk about it, where suddenly all the cells are destroyed in the spleen, and people and patients, young patients, lose all their cell counts. That is clearly an indication to try to prevent it from happening again with transfusion. Importantly, recurrent stroke, definitely we would consider putting patients on transfusion, and as I said, acute chest syndrome. Stroke and chest syndrome being the most common causes of death in this disease. So simple versus exchange transfusion, I've already alluded to this before. The advantage of taking the sickle cells out and replacing it with donor red cells, which is represented in the bottom diagram, is that the thickness of the blood, called hematocrit, is reduced. So when you do a simple transfusion, you raise the thickness of the blood, for instance, in this case, to 40%, and you have more sickle than hemoglobin A. Whereas here, when you remove the sickle cells by what we call phlebotomy, which is essentially something like giving blood, using a cannula to take blood out, or using a machine called an apheresis machine to remove the sickle cells, you can see that the thickness of the blood can be reduced without therefore increasing the propensity of sickling due to the transfusion. And you can see also that the percentage of sickle cells by the exchange is reduced as well as compared with simple transfusion. Here I won't go into detail, but just to say that there are specific indications for stem cell transplant for sickle cell disease, and this includes stroke, this includes sickle lung disease and nephropathy that is severe, and I might let Anthea talk about that. And in the final few slides, I'll just mention the two main drugs which have passed FDA approval. Obviously, we hope one day we will also get that in Australia. But this first one is crizanlizumab, which is a humanized antibody targeting the molecule called P-selectin. So P-selectin is a molecule that leads to the stickiness of white blood cells and platelets to the sickle red cells. So if you can target that sticky molecule, you can reduce the sticking of those red blood cells together to cause blood vessel blockage and infarction. And the main trial, called SUSTAIN, was published a few years ago now, had almost 200 patients, which compared people with between having the drug versus placebo, and you can see they were divided into the number of crises events, and in both groups, the more severe as well as the less severe, there was clearly an improvement in the probability that they would have painful crises in those patients who received the medication. And the other drug, called foxylotor, I always find it hard to know whether I'm pronouncing it correctly, but this drug is also very interesting because it inhibits the sickle hemoglobin from aggregating, because it binds, it stabilizes the sickle hemoglobin in the oxygenated state. That is to say, it basically increases the oxygen that is stuck to the abnormal molecule, preventing it from forming those rod-like fibers that we spoke about before. And here there's another trial called HOPE, where they were able to see that patients, that there were significant increased numbers of patients who had a response in those who received the highest dose of the drug as compared to the placebo or to a lower dose of the drug. And on the right-hand side, you can see that the mean hemoglobin level in preventing the red cell breakage was also the highest in patients who received the highest dose of voxelotor. Actually, I do have 2 extra slides, and that is to introduce the subject of gene therapy. Many of you will know my unit performed gene therapy for thalassemia patients. We have been trying to see if we could perform the sickle cell gene therapy trials in Australia, but so far we have not yet been able to achieve that, but we are continuing to try. This particular molecule called BB305 was in fact the one we used for thalassemia, but it so happens that it also plays a role in reducing sickle polymerization, sickle hemoglobin polymerization, because it acts like the fetal hemoglobin. And the way gene therapy works is that a particular virus called lentivirus inserts this particular gene into the genome of the patient. They then make this molecule, and this molecule then prevents sickling. And furthermore, my penultimate slide is to say that there are certain molecules which actually represses that fetal hemoglobin production. And therefore, if you can use gene editing to target those molecules which suppresses fetal hemoglobin, you will then raise the fetal hemoglobin to reduce sickling. And that is another form of gene therapy in sickle cell disease. So I come to the end, and I'd like to summarize by saying, clearly, as you all know, sickle cell disease is a common disease around the world, but is becoming increasingly common in Australia, conferring multi-system morbidity and even mortality. There are increasing efforts in newborn screening, but it remains a worldwide problem, causing an enormous impact on well-being. There are multiple pathogenic mechanisms, which I hope I've been able to go through in a very brief, but hopefully clear way. But they are also the way in the way in which research can be advanced, because these advances target those mechanisms, such as those molecules that cause stickiness of red cells. While hydroxyurea and transfusion remain the mainstay of therapy, exciting developments directly targeting those mechanisms are being developed, and there is clearly a continuing need for more basic and clinical research. And as I mentioned, I did not mention much about stem cell transplant because the pediatricians are clearly the better experts in that. Thank you.
Thank you, Professor Hall. At this point, we have an issue with the next presenter. So I'm thinking we are going to go to Professor Baba Inusa. We are going to have a patient testimony after Professor Baba Inusa, because Yemi is having problems to log in. So I welcome Professor Baba Inusa, who's just logged in. If you can just introduce yourself quickly and go into the presentation. Oh, Yemi, you're here. Oh, sorry. You managed?
Yes, I'm here. Yes,
I'm here. Are you going to manage to share your slides?
I'm not able to share the slides. I can just read it from my.
Yes. Yeah, I think so. So we've got all the bios in the brochures. So please go through and just check Yemi's bio. We won't go into detail to give our bios. We'll just quickly introduce herself and go in and give a patient testimony. Yemi, please. Thank you.
I grew up feeling like I didn't have a voice, or better yet, it took me a long time to understand the power of my voice. I've always recognized that I wanted to make an impact on people and taught for many years, and so I assumed that that was the extent of the impact I would make. I've always yearned for more though. Last year, I had the opportunity to speak at the ASCA conference in London, and something clicked inside of me. I realized how meaningful my story is and how strong of a voice I do have. You see, growing up with sickle cell disease, I always felt small. There were many limitations placed on me, so many expectations of what I could and could not do. And so I internalized those things, those positions. those stigmas. And it's funny, because although I internalized them, I didn't buy into them, if that makes sense. I knew from early on that sickle cell would not be the cause of my demise. I don't and have never viewed myself as sick, even when I've been hospitalized or deathly ill. I've lived a practically normal life, as much as I can possibly define normal. I travel more than some healthy individuals. I don't allow myself to be limited in the decisions I make. I led a group of junior high school students, some who had learning disabilities, on a college tour because I wanted them to understand that the sky is the limit and that they can reach any height regardless of the labels that were placed upon them. I have moved all over the U.S. and lived in Nigeria for several years during my adult life. So I have internalized stigmas and expectations placed on me on one hand, but on the other hand, I've lived a pretty free and amazing life. I've always lived within this dichotomy of power and limitation. So as I am continuously evolving, I have come to a point now where I decide to live to my fullest, not just in my physical life, but also in my thought life. I had the stroke at the age of 12 because of sickle cell. I received blood transfusions for years and years to manage sickle cell. I take medicine every day and have been doing so for the last 26 years because of sickle cell. I was pregnant with twins years ago and lost them because of complications of sickle cell. The doctor said it was either me and them or them. Serious relationships have ended because of sickle cell. I've been in and out of the hospital with crises, pneumonia, chest syndromes, so many different symptoms and sickle cell related reasons. My sister, who was my best friend, and my brother passed away because of sickle cell. So it has been natural to allow these things to make me feel like a victim or powerless or limited. But today and tomorrow and forever, I choose life, I choose freedom, I choose purpose. As we continue to go through the next several months, or maybe even the rest of the year on lockdown because of this pandemic, we too must decide to stand for ourselves, accepting the limitations of the situation, but not allowing the limitations to limit us, and not allowing them to define our peace of mind and peace of heart. I've been homebound with my 2-year-old daughter for the past 3 months, or for the past 91 days, or for the past 2,184 hours. Just me, her, and her grandmother. And it has been difficult because I am used to traveling, getting away, having my own space. It's been really hard for me over the last weeks to stay sane, to stay composed, and to not let out my frustration or anxiety on my daughter. And I'll be honest and say I have had moments. But I've come to the conclusion that it is so important to live in the present, to enjoy each situation as much as I can, even when it looks hopeless, and to look for reasons to smile, to dance, to laugh. These are things that I have had to do throughout my life to make it through the difficult, scary, and heartbreaking times. This is what has kept me in the place of power over limitations, power over sickle cell disease. It's a really funny balance, but daily we all must choose our reality and confess the reality that we have chosen. We must choose our joy, our peace, our love, so that we can fully live in the power that belongs to us. Thank you.
Thank you so much for that powerful testimony, Annie. Thank you so much. You always touch my heart with your story, and no matter how many times I listen to it. So at this point, we have Professor Baba Inusa, who's going to do another presentation. You can take it off, Professor Inusa, please. Thank you. Professor Inusa, are you here?
I need to share. Give me this power to share the screen, Agnes.
Okay, let me just do that.
But before, as you give me the power, I just want to just say thank you for this opportunity to participate on this platform. And can you imagine that I can get to Australia in just 1 second? So I'm now in Australia.
I
And
know.
it's yeah, and actually being in the same institution that I wanted to meet Joy, because we sit in committees and we argue different cases and we oppose each other, but now she's a friend today. So
Yes.
I thought, so what I'm going to do is just to run away with just a little bit. I know I have time limitations, but I wanted to tell you on some of the projects that we are running, and so that I just obviously Arise is one of the projects we're running, which includes a number of countries, and it's called African Research and Innovative Initiative, which is it's a project that is aimed at improving capacity in Africa, and a number of African countries are Nigeria, Kenya, and we're actually adding Zambia into that, and just in the process of confirming that, and 9 European institutions that allow to establish exchange to develop capacity and to help people through different aspects of training. And this project is for 4 years, started in January 2019. To determine the prevalence of sickle cell disease, we do that in Zambia, we do that in Nigeria, and also do that in Kenya. And then to facilitate engagement and to develop the individuals in terms of management. So there are 8 work packages. Obviously, the first one is staff management and coordination, but actually involves training in terms of e-health technologies, improved laboratory diagnosis, and kind of developing capacity in the management of sickle cell disease. I saw these questions and I absolutely love them. And so a number of people who may be on this platform may actually have asked the questions. But I think when you think about presentation, particularly on the World Sickle Cell Day stage, who are the best target that we want to reach? I think it might not necessarily be the patient, it may be the public, because public don't know much about it, because the patients already live and know and experience this. But actually, when you have families asking these questions, how do I deal with a toddler who often is sick from sickle cell disease? I would like to know more about sickle cell disease. How can I help my son with sickle cell disease? And you see, the majority of the questions are actually from parents. And it was very nice to listen to Yemi's story again, and every time I listen to it, it's like a new story. So I think ASCA this year again would definitely be engaging you. So it's a privilege to hear the stories from the people who experience it, and actually, and we also kind of after the patient session in ASCA 2019. We have presented the material at European Hematology Association, and we want to kind of work on it this year in a much bigger way. And I like the way that Joe has already just already talking about the multi-organ involvement. And also, Joe, I think I missed the first part, but you talked about survival and also some of the things that are very, very important in actually kind of influencing the survival of patients living with sickle cell disease. And you could see that a number of actions and steps that were taken actually led to significant kind of impact. And actually, I think the World Sickle Cell Day, which was actually established in 2009 for the 19th of June, is also an opportunity for us to actually engage with policymakers, engage with governments, and actually, I'm sure it's good for us to see whether that has an impact on the outcome of people living with sickle cell disease. And when we look at the various things that really affect people living with sickle cell disease, like Yemi talked about losing 2 of her siblings with sickle cell disease, the causes of mortality is actually kind of vary depending on the community, depending on the location. Obviously, in Africa, infection is still very key, very, very important. But multi-organ involvement, which Joy talked about, are very important. But I thought, I think Agnes said I should talk about psychological issues in sickle cell disease, but obviously I'll just kind of go around. But I think the reality is that I will need to also talk about what COVID has done to us. But when you think about the quality of life of living with sickle cell disease, there are a number of risk factors that can make things very difficult. Somebody that is suffering from acute or chronic pain, And then people who, talk about emotional relationship. Again, that was actually highlighted by Yemi's presentation. And also, and then issues that we know are very, very common with our young people, things like adherence. Again, I'm a pediatrician, so I think about children who are going into the adolescent period and actually begin to seek their self-independence and actually begin to think, why do I have to take this medication? My life is not all about sickle cell disease, which is true, but actually it's important to make sure that we can deal with them. And then we're talking about school absences, which affect their academic performance. And then the period of time of hospitalization, again, reduces their interaction. And this was a slide given to me by Masha, is a friend of mine. And she's kind of talking about the impact of, so particularly when we think about COVID-19, what is the impact on families? What is the impact in sickle cell disease? And really, this can generate a lot of feelings, a lot of very different responses. And these responses could be very difficult. These responses actually could be very challenging. And so when we think about all the various recommendations, particularly about COVID-19 management, again, some psychologists don't like the word social distancing. They want us to use more physical distancing than social distancing. But actually, if you're socially distant, you shouldn't be socially kind of separated from your people. So you should continue to maintain the social connection because those are the things that keep us, those are the things that strengthen us. But uncertainty about employment. So for example, in the United Kingdom, we have a system whereby people living with sickle cell disease and other who are described as vulnerable conditions actually have the opportunity to say, okay, you don't go to work because you are described as this, and your employer will have to keep you because the government will pay some part of the salary. But that provision is not available to everyone, to every country, and even the US, they don't have that kind of provision. So, but in terms of people are worried about their housing, losing their, they have to kind of make it clear for mortgage companies that people can have missed their payment for a period of 6 months so that people don't lose their houses. And so those are some of the things that people really, if you can't be assured of your housing, and then you also obviously at increased risk of developing mental illness as a result of a combination of these factors. And therefore it is something that leads to a lot of anxiety, becoming ill. And if I call and I talk to my patients' parents and I said to them, can you use one word to describe COVID to me? I've had various words. I have like almost 20 words from different people, things like anxiety, things like stressful. And then some of the young people actually feel it's more of a suppression that actually upsets them. So say it's making me a prisoner. So these things are experienced by other people. But actually, if you experience them in addition to pain management or the pain experiences, that makes it much more challenging for you. And so one of the things that we try to kind of encourage parents and patients to do is to continue to take their medications. So anxiety, just how do we respond to anxiety? It can help us to do better. It can help us to recruit all our resources and make sure that we do well in exams, to do well in various difficult situations. But also it can hurt us when we're overwhelmed by it. We think about the worst. So for example, like one of the things that I want to encourage patients with sickle cell disease to realize is that even if perchance you get COVID, the majority of people will survive. So for example, like we have had a data from the UK, and over 90% of adults who have had COVID, they actually overcome it. And that's similar to the population, the general population. Obviously, we still argue that sickle cell disease is a risk factor, but actually, when we look at the data so far, it is looking very promising that actually people with SS actually may even do probably much better. So they need to know that story. They need to know that that is possible, and people actually will get well. But anxiety can really cause a lot of problem. And then how do we manage stress? How do we deal with this? This is kind of a kind of really a chart that shows you one of the things that you could do: connect with people, connect with the various networks that you have, connect by various methods, and then I think I like this one. Take a break from the news. So sometimes I sit watching the television, and the same story comes up 30 times. If you watch it 30 times, it embeds more in your mind. So I think maybe just limit that, and then do some more fun things. Watch a lot of kind of good Netflix music, movies, and probably, yeah. And then we can, for example, you feel stressed, take action, get out, move there, and keep some structure. So for example, like during the pandemic, during the lockdown, you needed to have a structure to make sure you wake up, have a shower, dress up as if you're going to work, and also make sure that you eat food and you do it at regular time, not just, so some of those things were some of the things that actually could help us. So stay connected, calling just, so when you think about the psychological impact, think about how to deal with a number of issues, how to relate with the community, and also how to connect with other people. Then there are other forms of psychology that can be available to you. So we make sure that our psychology service is available, and we actually can connect patients virtually to make sure that some of the issues that they have can be dealt with. And then this diagram says, thinking about dealing with emotion as similar to cultivation. So if you need to, what do you put in your mind? Healthy seeds, healthy soil, facilitate germination. How do you have healthy seeds? The thing that you think about, the thing that you feed yourselves in, and then the environment that you kind of find yourself in, and so all of this would lead to you harvesting kind of a better fruit. So set intention for success, peaceful environment, prepare for the desired life. And I think I like again Yemi's comment. She says, and I know that I have a purpose. She's always known that anyway, but she just says it's become more and more clear to me that I have a purpose. I have something to actually give, and nothing kind of beats value. If you feel some value, you really can feel very much better. So I thought maybe this is some of the things that I think just to kind of highlight some of the issues. But if I had time, probably I can try and address some of the questions that people raise. But and I think let me just see. I hope my slide is there because I wanted some. I hope I didn't put. Okay, great. So this is it. All right. Joy mentioned about hydroxyurea treatment. For me, it is a very key thing that has really, really changed the perspective of sickle cell disease. And I encourage people to make sure that they get the right dosage, the right treatment. And I think that is very important because some people try for 2-3 months without really reaching the proper dosages. And actually somehow they're not able to recognize that that actually works very well. And then also you mentioned some of the new therapies that are actually been approved. And I think these are the options that are available to us. Hydroxyurea management, blood transfusion may be more limited, particularly in Africa, but actually where you have it, obviously the treatment remains really top in terms of really making the impact. But hydroxyurea is something that I have found of increasing value. What are some of the barriers? Obviously, people are worried about fertility, worried about all kinds of side effects. But actually, when you get down to it and look at it, actually, some of these problems are really not being described specifically for sickle cell patients. Particularly like the secondary cancer with hydroxyurea has been described in other myeloproliferative disorders, which are actually pre-cancer settings. So I think the story about hydroxyurea to really improve the outcome of life is very important. Bone marrow transplantation, yes, it's a mainstay of treatment, but actually it's very expensive. You cannot get it free of charge. So I know in the past it was like one of my patients about, I think 7 years ago, came and had a bone marrow transplantation in the UK. They came from Nigeria. They had to pay 150,000 pounds to get that treatment done. But that treatment now is about 500,000 pounds. So it is not that easy for those who have to pay for it. But at least but if you are entitled to the service, then obviously that is something that is available to you and is accessible. And also what the gene therapy has an advantage over the bone marrow transplantation is that you don't need a separate donor. But sometimes the donor availability can be the challenge in sickle cell disease because you may not get an immediate person that will be HL identical donor in terms of HL identical sibling. But obviously the other methods are looking at the haplomatch protocol and also looking at match or related donor. But the best outcome is a sibling match donor. So I don't want to talk about gene therapy because Joy has already spoken about that. But in summary, I mean, I just mentioned to you about our ARISE project and the fact that it gives us opportunity to work and develop a lot of skills in Africa. And then I think I didn't talk much about blood transfusion, but hydroxyurea is something that I think we should definitely pay a lot of attention, because that can be available all over the world, and it's cheap. Obviously, the monitoring can be modified to make sure that this is fine. And then this one, obviously, are things that are happening. Gene therapy is something that is really very promising. I don't know whether Joy was able to see some of the EHA presentations, but they're very, very interesting. So I want to say really thank you for the opportunity, and happy World Sickle Cell Day, all of you. Thank you. Agnes, I've finished.
Thank you very much. Yes, I know. Thank you very much. I had to wake you up so early in London. I'm so thankful that you had to join us. You clinicians, experts on this panel, all inspire me. So at this point, I'm going to call Dr. Anthea Greenway. So if you go through the brochures again, we're not going to give you full bios of all our experts and our caregivers and people affected on the panel. Please go through the brochure again. And Dr. Greenway, just quickly, Dr. Greenway has been our doctor for the time that my daughter was treated with sickle cell disease. And she's still part of, I call her that she's part of the family because we've known her since 2013. So Dr. Greenway, please take it up. Thank you so much.
Great. Can you hear me okay, Agnes? And can you see my screen?
Yes, yes, we can hear you.
Great. Okay, that's my slides. So my name is Anthea Greenway, as Agnes said. Some of my information has been beautifully covered by our previous presenters, so I'll skip through that in the interest of time. I think this is well known to our audience, is that sickle cell disease is a very severe condition for sufferers, and something that we really need to focus on in terms of improving health outcomes for individuals who are affected and their families. So we've had a very nice description of the some of the clinical manifestations. I won't go through those again, but I think thinking about things in terms of acute and chronic is one of the main ways that I often think about sickle cell. But I also just want to remind everyone that children and adults are not the same, and that's obviously my job as the paediatrician. But as Joy alluded to, some of the problems that we see in children and adults are very different. So problems like the dactylitis and problems like the swollen spleen that was very well described, problems like particular infections and a high risk of stroke are really some of the problems that we see often in children, and need sort of very good attention to make sure that these don't cause lasting problems for people, but sufferers of sufferers of sickle cell, as they and to ensure that they sort of reach adulthood and you know, with the minimal complications from childhood from their sickle cell. So we're very nicely guided in our therapy by a number of excellent guidelines that are produced in a number of areas in the world. And as you just heard from Professor Baba's talk, you know, a number of these guidelines are now being applied to places in the world where sickle cell numbers are increasing well beyond the load we see, certainly here in Australia, but even in the UK and the US. And as we've also heard, the number of treatments continues to increase. And I think that's one of the most exciting things for me as a clinician looking after patients with sickle cell. We have many more things in our tool bag, many more drugs and medications that may allow us to help patients with sickle cell. So hydroxyurea is really has been on the, you know, on as part of our sort of treatment for a number of years, but now we have up to 4 medications that are part of the options if you're in the US, and then we have the options of stem cell transplant in addition to transfusion. So how do we treat sickle cell for children in Australia? So hydroxyurea, we've heard very nicely how important that is, and that's really our mainstay and the main medication that we have available to us. And then different forms of transfusion are important. But really tonight I wanted to think more about the holistic care that is so important in terms of keeping patients and families well, having them engaged in our clinic so that we can make sure that we have that sort of opportunity to have the best outcome. So the one comment I would make about hydroxyurea is this drug has been around for a long time, and you can see the slide I've just put up there, which is one of the sort of early slides describing its effectiveness in this condition back in 2010. And really, we're 10 years later, and certainly this medication is available in our clinics, but it's taken that time and probably longer to really get it to most of our patients, and that's, I suppose, been a barrier to getting sort of treatment for many patients. We know, and we've just heard beautifully from Baba again, how much evidence we have that this medication works really well across the age ranges. And unlike many of the drugs that I need to use in paediatrics, there's lots of evidence in children of how effective this drug can be. And that's really exciting for me in terms of being able to talk to patients and families about how we might use this medication to keep people well, keep their children well. Transfusion support. So again, significant focus on making transfusion safe and available to many patients with sickle cell disease. And I think, as has been alluded to, for some conditions, particularly neurological, transfusion support is really important, and making sure we have good guidelines to guide in terms of how we give best and safest transfusion practice has been really important and continues to evolve in the last couple of years. And again, as has been discussed by Joy, this it's not really a new technology, but using red cell exchange and having this option for treatment in many of our clinics has also revolutionised treatment for many children and young adults with sickle cell disease. One of my most important jobs in the clinic is to keep my patients well and keep them at home with their families. And so really a lot of the activity that we do is about screening and prevention. So my job is to make sure that everyone gets to 18, graduates from my clinic, and then I send them up the road to doctors like Joy or Carly Mason at the Royal Melbourne. So, you know, in terms of guiding how we screen and prevent some of these complications, many of these things are really important. I just had a bit of a think when thinking about talking to you all tonight about what were some of the biggest challenges for the paediatric cohort, and I think this ties in well with many of the topics that Barbara has discussed. So we have little people with big challenges. So missing school because of pain, because of appointments, because of coming in to see annoying me who's doing the screening, and that really takes a toll, I think, on members of the family, but also the children that we care for. We know a number of children have significant learning difficulties, and these are often silent if we don't pay really good attention to finding out how everyone's going at school, and that's often related to problems such as silent brain injury. If you're in chronic pain, it's really hard to concentrate and to go to school and do your best. And I think these are really important things for us to be cognizant of as the clinicians looking after patients with sickle cell. And we know, as I showed previously, stroke has a much higher proportion, or affects a much higher sort of percentage of patients in the paediatric age group. So it's a really important part of my job is to make sure we're screening for that. One of our other biggest challenges is if sickle cell is not well known, and we have teachers and school nurses and other parents who don't know what sickle cell is, and that has a significant impact in terms of making sure we get best educational outcomes for our patients. One of the other biggest problems that causes significant psychosocial distress, I would say, is the problem of enuresis or bedwetting. And you know, we know why this happens, but it's a really hard thing to treat, and it's really challenging for a 15 or 16-year-old to have problems where they can't go on a sleepover or can't go to camp because they wet the bed. As I mentioned, some of our practical challenges is the rareness of this disease relatively, and so access to care in Australia can be challenging, and making sure we have consistent and equitable care for patients who may be needing to be seen in non-sickle cell centres. Making sure we have technical expertise to ensure that the screening process goes well and that we have full access to all of these treatment modalities. Access to medications. Can you believe even in 2020 in Australia, really we have difficulty getting access to things that we would say are standard, such as hydroxyurea, but in forms that are appropriate for children. And the costs are substantial, and I think these costs are not necessarily monetary, but relate to you know, employment and loss of productivity and needing carers leave, in addition to costs of travel and medication. I think it's really important, and one of my jobs as the paediatrician is not just the patient in front of me, it's the family around me, the family around my patient. So thinking about mental health and siblings and families and the impact this has on them is really important. But I think the future is really promising. One comment I wanted to make is many of those drugs you've heard so beautifully presented by Joy and Professor Baba, you know, these drugs are coming through much more quickly. So that sort of 10-year gap I mentioned with hydroxyurea, I think is unlikely to be the same for many of the medications that are now becoming available. The improvement in transfusion medicine is similarly happening at a very quick rate, and that's really promising and important for us. And we've heard already about bone marrow transplant and gene therapy. This slide's just to remind me to tell you that we know so much more now than we did 10, 15, 20 years ago about the other aspects of sickle. So it's not necessarily all about the red cell. There's white cells and platelets that are really sticky. There's parts of the blood clotting system that are also affected. And this knowledge is really important to help clinicians and scientists develop other targets in sickle cell. I'm not going to go through any detail, and certainly Joy's alluded to a number of them, but the way that we implement this in the clinic is that it's the capacity to really think about a multi-targeted approach. So rather than just having hydroxyurea, we might have a patient on a number of medications to really try and control their sickle cell and the different aspects of this condition for them on their life. We've talked about bone marrow transplant, and I think in addition, this treatment is moving rapidly into our clinics with vast improvements in success with this treatment, although certainly it's a treatment with significant risk. I think our important job as the clinicians is to really focus on how we help patients and families choose the right patient for a bone marrow transplant, and I think that's one of the really important steps for us as clinicians. Gene therapy, we've heard also, is a really important new technology that's coming, and particularly where this fits is this may well be something that's on offer to patients who may not have a bone marrow donor, and so that's only about a quarter of our patients will have a sort of matched sibling donor, and at the moment, so gene therapy may well be an option for them. I just wanted to finish, highlighting how important partnerships such as the partnerships that the clinicians in this group have with ASCA are, and it's really important in terms of helping us move some of this science into the clinic, but making sure we're listening to our patients and making sure that what we think is important is really what's important to the sickle cell community. Some of our local challenges in Australia, just to touch on, relate to some of the aspects that Joy mentioned. So the genetic diversity of our population really affects how sickle cell may be manifest, and our population is often quite different to the cohorts that we hear described in the UK or the US or even in Africa, who are much more similar often. That lack of data has been a real problem, but we are trying desperately to address that as soon as we can. And because we don't have neonatal screening, the ongoing problem related to late presentation of sickle cell, so children who miss out on the early care that's so essential. So we did develop this group that, as Joy mentioned, this is the Australian Sickle Cell Working Group, a group of clinicians, nurses and advocates, and also some pharmaceutical companies who got together last year to really think about how we might approach this problem in Australia. And where do we go from here? So this slide, the slide on the left is the World Sickle Cell Day that Agnes was really probably the birth of ASCA, I suspect, back in 2000 and, she might have to tell me, 14 or 15?
I think the 14.
14, yeah.
Yeah.
And the slide and the photo on the right is my team at the Children's Hospital today on World Sickle Cell Day. So there's a whole group of clinicians, lab scientists, haematologists, apheresis staff, day medical staff, who are also important in terms of providing care for patients with sickle cell. And this is how much we've grown. And as you can see, the field of medicine and science and patient advocacy around sickle cell is continuing to grow at that rate. So I think that's incredibly impressive. And I think we look forward to embracing this opportunity and future opportunities to work together. I will stop there.
Thank you, Dr. Greenway. Thank you so much. I'll quickly dive into Biba Tinga, joining us from Canada. She's the president of the Canadian Sickle Cell Association. Biba, take it, please, if you are there. Thank you.
Yes, I'm here. Hello, good morning, everybody. So I said I was going to start by thanking ASCA and the president, Agnes, my dear friend Agnes, for this kind invitation and for the opportunity to bring greetings from warm Canada. I'm really happy to be here, and especially to have the opportunity to share our experience as, how we deal with sickle cell and how we are living here in Canada. And I proudly represent today the 6,000 individuals who live with sickle cell disease here. And through our organization, which is the Sickle Cell Disease Association of Canada, our organization was founded in 2012, and it's a national umbrella for provincial groups who are working on the ground, to support patients and families living and dealing with this very debilitating disease. I'm going to start by telling you what we've done so far in Canada regarding sickle cell as patient, family, and support groups. We as an organization have established this organization to support, our main mission is to improve the quality of life of people living with this condition. So what we've done so far, we have 6 groups who are members of this national organization. So I think only 1 province to go. We've been able to get a newborn screening, in 7 provinces and 3 territories. So just 2 more provinces to go, and Canada is going to be covered with that. We've created and implementing a national research program, and that we're trying to attract the researchers, to come into the sickle cell field. And most importantly, again, we've put Canada on the map as the first country to pass a bill to recognize June 19 as Sickle Cell Awareness Day, following the recommendation by the United Nations and the World Health Organization. As you may know now, for us in Canada, June 19, we have a bill that passed, it's a law here. So we have Sickle Cell Awareness Day in Canada. And I invite you to do so in Australia, because I think this is how we can change things for patients and families, because we need to do, I see that today this organization in Australia has the support of the policymakers. It's very important. It's a partnership to work with the healthcare providers, the policymakers, and everybody, all the partners. So I think, Agnes, I know that you have that in plans with ASCA, so I'll be happy to share any information and then support the process. Now, so I've been the president of SCD since 2007. Prior to that, I was the vice president for 3 years. Of course, I've not done this work alone. We have a dedicated teams of volunteers, of patients who are also now coming and, supporting all our work, and also the parents themselves. So how did I get here? Again, it's because I'm a parent myself. I'm a caregiver. My first child was diagnosed when he was 7 months, and in West Africa, Sub-Saharan Africa. I'm from Niger originally. So that's when, without knowing, when the diagnosis happened, your first reaction is just to sit and cry, and my whole life was shattered. But after a few days, you understand that if you do not educate yourself, if you don't take control of the situation, then you know what? The person living with the disease is going to suffer or might even lose their life. So I started just trying to understand the condition, just asking questions, just reading anything I can find, because at that time it was more than 30 years ago. There was no internet, to go to and Google search. Even though, so I had to find books that were sometimes totally medical, information that I couldn't understand all of it, but I could at least see, okay, this is what I need to do. And I understand pretty early that I need to listen to the physician. I need to show up, for all medical appointments, and I need to take good care of that child. Well, what I didn't know at that time is that sickle cell could, what for me at that time it was a death sentence, but now sickle cell is not a death sentence anymore. So you can imagine, raising a child in this environment where you also face other limitations like stigmatization, the fact that maybe some people don't talk about it, so you can't have a support group. Some people going through it. Even when we used to meet with other mothers at the hospital, they will not really open up and talk. So you were really on your own. And I remember for the first time when a nurse told me that the hospital might not have blood for him if he needed it, you know, in case, in a sudden crisis. Then I started looking around, calling people to come and donate blood. And without knowing, maybe I think that was the first time I started advocating, you know, and really doing more than just being a parent and bringing my child to his normal doctor's appointment. So fast forward around the age 15, when my son was around age 15, we moved to Canada. And that's when everything changed, you know, because he was able to have, you know, access to good care, better care, I must say. When we got here, he had a growth delay, 3 years, and he was really frequently at the hospital, you know, and he was missing school. So with that, again, you know, that was impacting, you know, his emotional and mental well-being, you know, always feeling like you can do better, or you would love to be like everybody, but you can't. So he was able to have, you know, a break here, you know, just the fact that, you know, the pain was well managed, and he went on to the blood transfusion program, and then he started growing up, and I saw a different person emerge, somebody that now we can talk about future plans. And myself as a parent, you know, I realized that, okay, I need to just raise this child well. What I mean by that is that, not that I wasn't raising him before, but you raise a child that you think has a condition that will limit, you know, his life expectancy. So the way you deal with that child is different. There is guilt. There is also the fear of losing the child. So you might not really treat him maybe like you will treat another sibling that who is healthy. So that also impacts the family life, because I have 3 other children who are healthy, do not have sickle cell. And even though one of them is a carrier, and sometimes, you know, this is the reality of sickle cell in a family. It's going to impact the siblings. And if as a parent, you are not careful and you don't pay attention, you might also miss something there. So just Canada was good for my son. Today he's a young adult. He's independent, living on his own. He has a career. He's a pharmacy lab technician. And all that is thanks to better treatment option, because he was able to go to school, to college, and graduate. And I was able to have more time and advocate and be where we are today. And I must say, but with sickle cell, we have to stay connected. We have to stay informed. We have to educate our community, because what people don't understand is that even with all these new treatment options that are available now, you know, we are happy. We are in a new era for sickle cell, but we still have to continue to fight, because even when you have the care, it's not a guarantee that, you know, you will have access. Even if it's available, you have to fight for it. And once you get it, sometimes, you know, it's about policies. It's about maybe sometimes also that, you know, sickle cell manifests itself differently, you know, and one treatment works for one person and it might not work for the other person. So we have to continue to push for more research to make sure that, you know, there are more treatment options so that everybody can find what works for them. So also, we have to break the stigma around sickle cell in our own communities first, you know, the way we view it, you know, the way that talking about it, it's very important. Just have a support group, sharing, you know, the emotional burden, and also going into maybe therapy, because also, as for myself, I can speak from my own experience, you know, when my child was growing up, you know, we didn't talk about, you know, talking about the condition. It's, you know, the emotional aspect of it. We will just deal with it, you know, physically. So go to the doctor, take the medication, the treatment. But then when the person is sad, when the person is not feeling well, when the person is down, we'll just, you know, pray sometimes, and then which sometimes, you know, it helps. But I'm a big advocate, you know, of, you know, taking care of your mental health, you know. So, and that is important, being able to have relationship, you know, to make connection, you know, to find love despite everything, and to keep a career. So that's why we do what we do, you know, as advocates, as parents, we support them. And I'm really, really, really happy to see that now even the patient themselves are becoming, you know, patient advocates, you know. They have to advocate for themselves every day when they go to the hospital, or they have to be there, you know, to take care of their own. But at the same time, they also now stand with us. Today we're going to have a virtual event in Canada. If you're not sleeping in Australia, you might join us. It's 5 to 7 p.m. And we have a panel of caregivers of patients who are going to share their experience, coping strategies, just to tell us, this is how we are doing it as a family, or this is how I'm making it as an individual. This is how I'm keeping my relationship, my career. And it's very important that, we talk about it. And I think doing this kind of international panel is very important because we can learn from each other. We can share also, information and strategies. So I thank you all today for listening. Thank you.
Thank you so much, Biba, for that insightful presentation. I think you and I share the same passion as parents and ending up being advocates without knowing. But it's been a good road, and we both love what we do. So thank you so much. At this point, we have Dr. Nkongolo Kalumba, who's also an ASCA scientific advisor, who's going to also do a presentation. Thank you very much.
Okay, thank you very much. I just want to prepare with my slide. Okay.
You are able to share the slides, are you?
Yeah, just a sec. Give me a sec. Just get my presentation. Just a sec. So share slide. Okay. Are you able to see?
Not. Oh yes, now we can.
Can see. Okay. All right.
Thank you.
Yeah, just. Okay. So thank you very much for the opportunity you've given to me to make this presentation, and it's a pleasure for me to be here and to share this talk about sickle cell disease on Sickle Cell Day. It's always difficult after 3 hematologists and a number of people had spoken. Anyway, in French, usually said, la répétition, c'est la mère de la science. So the repetition is a mother of the science. So so my talk is basically sickle cell disease, the progress and challenges. So this is the overview, as you can see. So we're going to review the progress made so far to date, and then we'll discuss the challenges and the future perspective. So since 1910, Dr. James Eric is the one basically who discovered the sickle cell on the slide of a patient who came from Grenada. After his intern, I've showed him this slide, abnormal slide. So since then, obviously, sickle cell has been known before in Africa, but it didn't reach the Western literature until 1910 when James Eric published it. But from that time, you can see that some progress made. Obviously, it took so long time. This is 1910, and Dr. Pauling in 1949 is looking at the molecular in the hemoglobinopathy, and in 1956, basically the molecular, the hemoglobin structure was established, and the molecular disease was basically known. But it took like 40 years, and there was no much progress until really 1980s, when we saw that there was improvement after the initiation of a number of interventions, including a prophylactic oral penicillin, vaccination against the encapsulated bacteria, and newborn screening test. Obviously, as time goes, introduction of regular transfusion and hydroxyurea and the bone marrow transplant, and now we're looking at the gene therapy. So things start moving. So we can say that initially the progress was disappointingly slow. After the molecular structure has been established, there's no much, and some experts will argue that sickle cell disease has been neglected, although just being is also one of the most common genetic conditions. monogenic condition we know. So this slide again just show the progress. So in 1990, from James Eric, and through you can see how the progress, but really the takeaway message is that is in the 1980s when things start really moving forward. And this slide, you can see again the impact of these interventions, which really started in the 1980s. And the life expectancy in a sickle cell disease patient has significantly improved then, initially going to below 5 years, and now reaching 40, 50 years on average in Western countries. However, having said that, there's still a gap. If you look at on your left side, so this is the slide which compare all Americans, so those with sickle cell disease compared to those without sickle cell disease. So there's still a gap in of decades between the life expectancy for both two groups. So obviously there's still work to do. So the other contributing factor for the improvement, obviously, our diagnostic method is significantly improved. But I have to mention that hemoglobinopathy, hemoglobin electrophoresis already started in the 50s. But now it is more sophisticated. You can do autonomous densitometry and genetic DNA testing. So all these facilities have significantly led to significant improvement. So the newborn screening test plays a significant role in improvement, because if you screen when they give them early, then you can intervene. So all those interventions, so including oral penicillin and vaccination, cannot take place if you don't know whether the patient have a disease or not. So in the US, we can see here already in 1960, they started screening, and by the 2006, all 50 states of the United States do universal screening. So in Europe as well, you can see this slide is a busy slide, but however, the European community also recognize the importance of newborn screening tests, and that's been very useful. So if you look at how that's impacted in the US, so you can see that the children up to younger than 4 years, there is significant reduction up to mid 40s, 44, 43% in mortality, which is quite significant. So you can see again here, so 68% age of 0 to 3 years, 39 from 4 to 9, and 24% from 10. So as older you become, the mortality tends, so you reduce the mortality below 5 years, but there's an increment of mortality above 5 years. But all this come again with contribution of some other scientists here, Dr. Heber, who initiated research on the concept of pathophysiology of sickle cell disease. In the past, the belief was that sickling was all it matters, but this has changed since Dr. Hebel has initiated this research on cell adhesions and obviously multi-organ dysfunction, as well as free radicals implication. So we just to review again, so I think my predecessor have already spoken about this. So there's obviously hemoglobin S polymerization, but you have other factors like sterile inflammation. So the role of white cell as well as a platelet. So increased adhesions and upregulation of some chemicals such as p-selectin, which basically lead to vascular endothelium dysfunction, contribute significantly. Obviously, the release of hemoglobin of course, in the serum, and the release of arginine also play a role in pulmonary hypertension, which is because of reduction of nitric oxide, which basically become a hallmark of adult complication with a significant risk of mortality. So in the new therapy, because of our understanding exchange, obviously that have led to improvement or significant initiation research to establish some other therapy. Hydroxyurea, I'm not going to repeat, is one we recognize has made a huge difference in the outcome of sickle cell disease. This has been published in 1995 MTA hydroxy study. And also the other therapy which modify your hemoglobin, so reduce your hemoglobin polymerization and modify your molecular defect. So include also voxelotor. There's a group of therapy which basically prevent oxidative stress. That's where egg-glutamine oral powder intervene. Although there's concern about compliance because the patient has to take 2 to 3 sachets in a couple of times a day. And the therapy preventing additions, obviously, the main of this is crizanlizumab. Now, if you're looking at this, if you talk about COVID today, so one can say, look, COVID, we know that also lead to vascular dysfunction through upregulation of selectin P, whether someone of sickle cell may be at a high risk of this. Theoretically, yes. However, the data need to come in to support this. So this again, so the US study, so if you look at this, so about 100,000 people live in the US approximately have sickle cell disease, and it happened in 1 in 360, and for Black community, and 1 in 3 Black of African descent is born with sickle cell trait. So that's quite a significant number, and it's more than many rare disease, genetic or metabolic disease which are being screened. Now, factor which really have led to this improvement is the universal newborn screening program, and initiation of prophylactic oral penicillin and vaccination against encapsulated bacteria, introduction of hydroxyurea, use of transcranial Doppler for the stroke and the silent stroke, and introduction of regular blood transfusion. Now, what are the challenges? All these are good, but if we look at this, so that progress in sickle cell disease has been very patchy, and there's certainly a lack of globalization. So the life expectancy is still so behind the normal population, although it has improved. And the one of the curative method, the therapy, which is a bone marrow transplant at the moment, has a limitation because of limited suitable donor availability. So it's about estimated about 10% who have access to bone marrow transplant. We hope that with gene therapy, these difficulties will basically be resolved, as there will be no need for suitable donor for the gene therapy. So the other challenges, so there's a significant and rapid change in demographics in many countries due to increased immigration. And the last one is the psychosocial effect of sickle cell on individual and family level. This hasn't been really attract many attention, although the current system is a holistic model where you involve the family and the child, looking at the whole angle, so mental as well as physical. But many countries don't have those facilities. Now, if we look at this, so in the world today, it's estimated like 400,000 babies are born with sickle cell disease each year, making it the most common genetic disease. Of those, 300,000 about are born in sub-Saharan Africa. And of those 300,000, 50 to 90% died before 5th birthday. Think about this. This is unbelievable. So it's quite starting. So many lives being spent, but I think the effort hasn't been at the level of magnitude of the disease. Now, if you look at this slide, you can see Nigeria, Republic Democratic of Congo, Tanzania, Uganda, really on top with a total of this. So the rest are in a Western country. This slide again does show that Africa is still leading in terms of birth prevalence of sickle cell disease, homozygote, compared to the rest of the world. Again, this is for heterozygote, is the same, and for obviously for deaf is the same too, which is striking too. Even in the US, people with sickle cell disease have less access to comprehensive team care than people who have other genetic disease, such as hemophilia or cystic fibrosis. This is from CDC. The reason for this is unclear. I think there's certainly need for more people to advocate for sickle cell disease. And I can't agree less that I think the disease has been somehow neglected in many places of the world. But what is striking is that the countries' low socioeconomic possibilities has been affected the most. So this again, we can see in Africa, survival rate under 5 years is about 10%, which is crazy compared to 96%, 99, high 90s, mid 90s in the US and the UK. So this slide just show you the effect of sickle cell disease on daily life. This is social psychological effect of sickle cell. More than half, they've been feeling that the activity been reduced, and you can see statistic. And this is again to show the contribution of newborn screening tests. This is a study done in France and the UK. So this just attract your attention. As we go, we can see here the medication. Well, of course, we're having new medication, but the prices, the cost of this medication is improving over time. And this again will have an impact on countries with low income. So this study on effect on psychology on a patient on a sickle cell. This is done with a review of 25 research paper done in Africa, Europe, and America. So there was all sorts of issues. So alteration of conjugal relations. I think people was talking about this, resistance of the parent to social and to the family, early death, anticipatory. I can't imagine people are living with sickle cells, some lose their own children or the sibling. It can be so hard. So everything can be seen from depression to anxiety, feeling of rejection, stigma. So the certainly huge burden of psychological effect caused by the disease. So immigration is contributing to the Western country, though. You can see here from this slide, people migrate, a number of them have sickle cell disease. In Australia, you can see previously in the early 1851 to 2019. So most people who migrated to Australia came from the UK. But this is kind of changing now. We have seen many African, you can see they're all the African, most of the big cities in Australia, they are also located. The complication of this too is also the understanding of the disease, because people came from different countries, they have a different background and cultural background. So, and this survey that show a number of people, up to 15%, can believe that the sickle cell is caused by God, or is because of God's will. So this, there's a work to do in terms of educate. So you go from here. We need a global effort and coordination to really have a real meaningful progress. So for the moment, the progress is there, yes, but it's patchy. Universal neonatal screening to be expanded to the country with poor resources, particularly with those with high prevalence. I was glad to hear Professor Anissa was starting a program in Africa, which is really things which should be done, because that's where the bigger number of sickle cell disease are coming from. We need to support other testing, such as antenatal testing and prenatal diagnosis, particularly in a country with poor resources. Even prophylactic penicillin, most African countries do not have this access to these cheaper drugs. So this can be certainly, if there's a global coordination, be made available. And vaccination these are going to significantly reduce the mortality in poor countries. We have to support a multidisciplinary model in a place where they cannot afford, and obviously promote and try to support the psychological effects of management of people with sickle cell. So in conclusion, so sickle cell is one of the most common monogenic inherited disorder affecting millions of people worldwide. And it is a multi-systemic disease with significant morbidity and mortality. Here I would like to say, although the the life expectancy is improving in Western countries, this will lead to is leading also to increase morbidity as they get, the patient become adult, they have more morbidity related to the disease as well as related to the therapy. The psychological burden is quite huge, and we need to address that. And obviously, although the progress has been made, but still a lot remains to be done. So I thank you for your time, and just for people who migrate from high risk countries, just remember, even if you remember to know your sickle cell disease status is very important, and that can really change a lot of things. Thank you for your attention.
Thank you, Dr. Kalumba. We'll quickly go into Sophie because I just said we apologize because we started late. We'll be running a little bit late. So Sophia, please take it up as a patient testimony again. 5 minutes. Thank you.
Thank you so much, Agnes. I'd just like to personally thank Agnes for giving me this opportunity, and to all the haematologists, professors and health leaders who have taken the time during this presentation to shed light on sickle cell disease. In the 27 years of living with sickle cell disease, I have never felt encouraged to have the conversation with a health professional about the psychosocial effects of sickle cell until tonight. Often patients are given a diagnosis and a treatment plan that focuses on keeping them alive and physically healthy, and is often treated in a clinical biomedical way, which doesn't address the social and emotional impact of this disease. When you live with sickle cell, it's a huge part of your life. A sickling crisis not only debilitates you physically, but living with a condition that has the potential to cause so many morbidities can cause feelings of isolation, fear of death, fear that you're unlovable, and causes long-term anxiety and depression. This is often so hard for people with the condition to verbalize, but once we break that stigma about talking about it in our personal lives, we can have that courage to speak with our health professionals, and we can tackle the mental health concerns associated with sickle cell. When I was diagnosed with avascular necrosis at the age of 13, my haematologist prescribed me a medication called tramadol. Now, I've taken this medication for over 10 years, and at the time, I wasn't informed of its antidepressant qualities, and I missed a dose one morning, and I wondered why I suffered a loss of mental clarity, why I felt depressed. I didn't feel like I could get up and shower and get on with my day. And it wasn't until I started doing my own research that I realized that tramadol has monoaminergic qualities, which obviously affects your neurotransmitters within the brain. So I wish I'd had a clinician at the time explain to me that being on a medication for such a long time is going to affect you mentally, it's going to affect your clarity and how you feel about yourself, and about the long-term psychosocial effects of it, which is obviously a part of managing sickle cell disease. Having said that, all in all, I think having your own voice and advocating for yourself and having these kinds of conversations are so important to be able to get the word out and to be able to humanize the condition. I think oftentimes we get so caught up on diagnosis and medicalization of the condition that we forget that there's a human being behind sickle cell disease, and we have our own thoughts and feelings and emotions that go with the condition, and we really need to view the person holistically and in a humanistic way, and really recognize that they have a life, and they have loved ones, and they just want to lead a productive life and be able to share their story. So I just want again to thank Agnes for this wonderful opportunity, and thank you all for being here tonight, and happy World Sickle Cell Day 2020. Thank you.
Thank you, Sophia. Thanks for your lovely testimony. At this point, we'll take it up to Dr. Catherine Mueba, who's our psychiatrist on the panel. Dr. Mueba, please. Thank you. Dr. Mueba, are you there?
Yes, I'm here. Sorry, I forgot to unmute. I was just saying I'm not going to share slides, but I'll just have like a conversational approach, talking about the psychological effects, which Professor has already alluded to, which is brilliant, where he talked about the psychological impact, especially during the COVID period. So we all recognize the impact of sickle cell disease. It's a long-term condition associated with pain and other complications that go along with that. And they are the psychological effects which we heard already about, depression and anxiety. And Sophie puts it nicely about her own experiences and the need when we're looking at the patient to look at other aspects of their life as well. All those problems can lead to significant distress for them. And sometimes it's difficult to see which one is presenting. Is it the psychological problem or the physical problem? Because then it leads into more hospital admissions and so on. And people may tend to become more dependent on other people for support because they've been unwell for that long, and that can impact on their own well-being. And when you look at maybe people who are in jobs or in schools, other people can deem them as being, lazy or weak, and maybe even faking some of the presentation or symptoms that they may present with. And that's important to recognize. And for them, some studies have also shown that it's the same with healthcare givers as well. In hospital, sometimes people may be seen as drug seeking. Sophie referred to the tramadol. If you've run out or you haven't collected your prescription and you feel terribly unwell, you can go to the hospital to try and get more of the tramadol. So some healthcare providers can deem that as drug seeking, or somebody is addicted, and make sort of those accusations. And studies have shown that that can be the case, leading to mistrust or absenteeism from work and school. And again, the sufferer reduces their self-help, their help seeking, and that has a more impact on them. So all those psychological effects can have life-changing effects on the individual, leading to poor well-being. They can't function as well as the other person can, and the quality of life can be quite poor. Some studies have shown that actually 69% of people presenting with a physical health symptoms similar to sickle cell disease can be 69% of people presenting with physical health problems can actually be clinically depressed. And so a quarter of people who attend A&E with really bad chest pain could be because of a panic disorder. So when the person with sickle cell presents with some of the symptoms or with the acute chest pain that we heard about before, it can be one of the acute presentations, we need to be mindful as well. Could there be a psychological element to the presentation? So it's extremely important that we make an early diagnosis for any psychological consequences so that we can treat that as well and prevent any unnecessary suffering and further investigation of the physical problems that they're presenting with. So it's important to recognize the pain, the acute pain crisis that they go through. And sometimes with the additional complication, the pain can be quite chronic, can become very, very chronic. And the treatment will need to be referring to the biological side, the psychological side, and the social side. I'm not going to talk about the biological side because the hematologists have talked about all the medication that's available. But on the psychosocial element side of things, studies have shown that psychosocial interventions do help when they complement the medication treatment that's available. And most studies make reference to other conditions rather than being specific to sickle cell disease. And that's why it's important about the research that is being talked about to develop something specific as well to the sickle cell disease sufferer, so that the treatments are individualized and target the kind of presentation that they present with. One common such treatment is called cognitive behavioral therapy, or CBT, where it addresses what the individual's thinking about that can interact with their feelings and then also interact with their behaviors. And the CBT therapists will target the thoughts and also the feelings so that they can disrupt the negative behavior patterns that they're going through. And that can be done in a group setting or also one-to-one, but there's a lot of online resources as well, which an individual can do that at home or through self-help manuals. And people have been helped in terms of their occupation or accessing health services, and also addressing stigma, which was talked about nicely by Beaver advocating that we reduce stigma for people who are suffering from sickle cell. Another important element in terms of helping individuals psychologically is to help with improving resilience. Resilience, or in other words, the bounceability of an individual, is where they are able to deal with stress in a better pattern than if their resilience was less so. And one way in which to do that is connecting through the social groups that are set up. And I know there are quite a few social groups that are set up with within the sickle cell, arena, and things like ASCA as well is important about the work that you're doing, organizing such conferences, and a lot of other things that you're doing, raising awareness and bringing people together so that people can identify with other people who are suffering. Coming to stigma, one of the questions, I'll briefly just go to the questions that I was asked so that we can start addressing them now. One of the questions was about how can we deal with stigma? And like I said, Biba did make reference to that, but one thing that we can do for ourselves as people who are suffering from the condition is to remain up to date, with the information about the condition, so that when we go to see a healthcare provider, we are able to say about what we know about, what we are able to share and collaborate with them. Sophie made reference to the fact that it was a diagnosis that was given to her and the treatment was sort of done to her. But we're in an effort to reduce stigma, and we're collaborating and knowing about the condition as a patient, then you work jointly with the hematologist or other healthcare providers. And one of the things in my practice, you see from the bio that I work with people who have addiction problems, we probably prescribe medication for them in that setting, and we ensure that they have a plan, maybe a written document about their condition, so that if they have to go to a hospital where they're not known, that stigma is removed of just wanting maybe opiates or other medication that we prescribe them, but they have this written treatment plan or a pain plan which they can take with them so that other providers can see and remove that mistrust. And having like a symptom diary as well can help, so that wherever you go, you can show people that this is where I'm at and that's why I'm presenting to hospital, or discussing it with occupational health at school and at work, to remove all that mistrust and accusations that can come about. The second question that was asked was around the paucity of data because the condition is so rare and in the people of color. How do we contribute towards improving the data that contributes to the research towards treatment, diagnosis, and care? And for that, I thought perhaps the hematologists would have been best to address that question, and I think they have. All of them have talked about, future trends towards treatments and more research. But I think as a group and what you're doing as ASCA, raising awareness and helping people understand that actually the research is important and therefore the participation is improved, and facilitation with the societies like this one helps engage both the health providers and the patients. Some studies have shown that previously patients would engage in the research but have dropped out, and that could be because they've become unwell. So the dropout rates in the research have are much higher than in other standard research, and the attitudes towards that can improve and help with the stigma. The other question was about how do we instill an at-home practice that can help address social issues and empower the patients with sickle cell disease. I think that's a brilliant question, and I think this is what Sophie was talking about, that she had to learn and research about her condition. One of the things that I can refer to is something called the 5 Ways to Wellbeing. The New Economic Foundation did a study where they looked at people and what 5 things that helped improve people's well-being and made them happier than those who didn't do that. And they looked at connecting with other people. I've made reference to connecting with social groups and other family members and carers, connecting and being able to talk with individuals about how we're feeling and so on. And also learning. It can be anything. You can learn something new. You can learn maybe on YouTube. I call it YouTube University because there's so much that you can learn. And when you learn about your condition and other things, it helps in terms of increasing your assertiveness and being able to seek help for the things that you've learned about. The third bit of the 5 is the moving, the exercise. Again, we've heard that exercise does help, obviously within limits and what you're able to do, but moving and having a structure where you can exercise and add that movement helps in terms of building resilience and maintaining well-being. And taking notice in terms of, practicing mindfulness or gratitude, being aware of things around us can also help contribute to the psychosocial support and empowerment at home. And another one is giving. I know sometimes when people who have long-term conditions may feel that they have nothing to give, but we all have something to give, whether it's a smile or sending a text or asking another sufferer about how they're doing. That helps us feel good about ourselves. In the Bible, King Solomon talks about our own souls being nourished when we're kind. So even out of where we feel that a sense of lack, we can still give something and it helps us with our well-being. And that's something that we can do with no extra money. And where necessary, resolving conflicts, sleeping well, eating better, all that helps towards improving our well-being and making us deal with the physical illness better. The next question was, I would love to know more about the psychosocial effects of sickle cell disease. I think I've made reference to that at the beginning, the psychological impact of the disease. And how can I manage my health? Again, if it's in terms of psychological health and managing that, I've made reference to the 5 ways of well-being and how we eat and move and so on. The next question was about the impact of COVID-19 on the medication, and somebody is concerned that we might run out of good medication like hydroxyurea. I can't comment on that, I'm afraid. I think maybe the hematologist might help me on that. But I know obviously most industries have shut down over this period, and therefore there may be an impact, but I wouldn't worry about that now. And then we can just see what happens. Most likely there'll be alternatives if there's any changes in treatment availability, medication availability. And then the other question was, how can we focus on challenges associated with sickle cell? And I think, again, I've made reference to that in what I've already said. And how do you overcome depression, low self-esteem, and fear? And I think the psychosocial interventions that I made reference to is extremely important. Being able to talk and being aware of symptoms. What is depression? What is anxiety? What does that look like? How would I feel? How will I know that this is what I'm experiencing? Being aware of those symptoms and educating ourselves is important. And also talking about it, talk about it with the family, about how you're feeling, your carers, your GP, the hematologist, and practicing the 5 ways to well-being as well can help in terms of dealing with that. And then the important thing which I wanted to emphasize is about getting help early. Because when we get help early, it then helps us deal with the issue, and that will have a positive impact on our physical health as well. Okay, so that was it that I wanted to say and share.
Okay, thank you so much, Dr. Mieva, all the way from the UK as well. Thank you. Sorry to wake you up early, and sorry you are running a bit late. At this point, we'll go to another patient testimony. Natasha, all the way from Zambia. Please take it up. 5 minutes, please. Thank you.
Hello, everyone. My name is Natasha. I am a sickle cell warrior. I am 28, turning 29 this year. So for me, the thing I can talk about the most is just that people don't really know much about sickle cell anemia. And from my own testimony, I would say most people say, I've actually gone for a lot of prayers, by the way, because people think sickle cell is some kind of witchcraft or voodoo thing going on, and they don't actually believe in the science aspect of it. So I think that's one thing that drew me to becoming an advocate and speaking for this cause and just educating people on what it is. And I think the biggest issue for me is reaching out to places that don't really have like TV and radio where these people can be reached in remote areas and they don't really know much about sickle cell anemia. And so I've just really been connecting with different people, just trying to educate as many people as possible. And I feel for me, I think my mom gave me tough love. And I think that's one thing that has helped me over the years with overcoming circumstances of depression and fear and anxiety. I think I have a very strong will. And so in that, I decided to actually, I have like a Facebook page where vulnerable people come to me and speak to me about how they feel. And it's important to just have a platform where people can come and speak to you freely. And there's so many warriors out there that just don't want to speak out and come up in the open and say that they're warriors because they're afraid of what society is going to say and treat them. And while I have experienced a lot of negativity from the public, that doesn't faze me because I know who I am and I know what sickle cell is, and I've studied and learned a lot about it. I'm in medical school at the moment, and I'm just really, really excited for this journey. And yeah, like Catherine said, it's really, really important to just have like a support group or partners that you can speak to in times when you feel it gets a bit overwhelming. And for me, who's in med school, also the pressure of school, med school is very, very demanding. And sometimes I don't really have the will or the strength to carry on. And so it's important to have a really, really strong support group to support you through the journey. Thank you so much, and happy World Sickle Cell Day to everyone.
Thank you so much, Natasha. Thanks for your testimony. At this point, we are going to go to Marjorie, who's a caregiver, to just give a quick testimony as well. Thank you, Marjorie.
Thank you. Thanks, Agnes. Thank you to all. And hello. There've been very good presentations, really, that have been made, very informative. And I must say, I really can relate to literally all the presentations from the clinical side to the psychosocial side, and just, you know, even at the household level. And I, as a caregiver of a child, a daughter who's 14 years old, can relate to a lot of issues that are current in the sickle cell world. And particularly when you look at issues of just what is going on from the psychosocial point of view. I actually happen to be a PhD researcher in sociology and chronic illness, and specifically sickle cell. And I was driven to come to this stage of my studies because of obviously being a caregiver of a young child who has had a lot of issues in her life of sickle cell. She was initially diagnosed with sickle cell at the age of 7 months and had to have her spleen removed by 11 months. She's our first child, and so obviously, you know, as parents, you know, your first child, there's a lot of issues going on there, the anxieties, and Viva did allude to this earlier on, the anxieties you feel about having a child with this condition for which you've come to know has, at that time anyway, 14 years ago, really was not presented with the sort of unknown cure, as it were. And bone marrow, of course, was being spoken about, but it was obviously something that was still quite not easy to reach. And yeah, so there was a lot of anxieties, a lot of challenges ahead of us. And as we got to know the condition, we began to know that this is a condition that requires a lot of care and management, both at household level as well as from the clinic side. And so in our journey of dealing with sickle cell, we've come to understand that just getting to have our child cared for as far as managing sickle cell in terms of attending to the necessary doctor's appointments and attending to the necessary care from home was paramount. And one of the things that I must say as a caregiver that has definitely shown a gap is the psychosocial aspect of sickle cell, because as a caregiver, you actually get to realize that sickle cell, as much as it definitely does affect the sufferer physically, emotionally, and all that comes with it, it has serious impact on the family as a whole. And it's from that point, it's from that aspect that I began to research. I began to interrogate systems that are current, both the clinical side as well as the social side, and came to realize that there are some gaps, and I'm still searching, because of course I'm still researching from the PhD point of view, but they are real for caregiver, and you are not really in this journey just sort of given the physical care for the child as far as taking them to the doctor's appointments and so on, but you are in this journey, particularly if they're young, to care for them in terms of the emotional side of things as well. And so really what I've come to learn, and appreciating a lot of research, scientific research that has gone before us, I've come to learn that if we don't advocate for the psychosocial structures and systems that should be put in place, a lot of our warriors, so to speak, really sort of have a challenge in terms of dealing with this condition early on in years. And I'll say this very quickly as I get into some of the questions that were posed. They have a challenge earlier on in years because this is a condition for which starts in childhood. Really, they're babies at the time for most of them when they actually get to start, get to suffer from this condition. And from that time on, you get to realize that for most of their livelihood, really for most of their life, they will have to go through this condition. And so it's from that point of view that I am advocating for very robust and strong psychosocial structures and systems that will help not only the warrior or the person who's suffering from sickle cell, but the people that surround that person, which in this case will be the household. At household level will be the mother, the father, or siblings, and whoever else is within that community. And so I'll go quite quickly into, because I do realize that we're running out of time, I'll sort of go very quickly through some of the questions that had been asked. One of them is, how can I help my son with sickle cell disease live a healthy life? My experience really here, and I'm not speaking from a clinical point of view, just general, my experience here is just make sure that the child has a healthy meal, and healthy meals don't have to be expensive. They are eaten properly, and of course they do remain well hydrated, you know, in most days, regardless of the weather. If it's very cold, of course, give them some warm drinks. If it's warm, you know, give them drinks that are sort of room temperature, and the other foods that will sort of help them really have a healthy diet in that sense. The other question that was asked was, I need to know more on how to keep my daughters safe during this pandemic. We're in the UK, and for those that are in the UK, I think one of the things that have been pronounced is about shielding those that are vulnerable. So my daughter has been shielded during this whole time. But as we're sort of monitoring the situation as far as the pandemic is concerned, we've been able to slowly take her out for short walks around and still bring her back in. And we're all sort of just trying to practice, you know, trying to make the environment safe for her as far as shielding is concerned. So I think that's one of the things that you certainly would have to do in this case during the pandemic. The other question was, my boy is SS, going to be 12 years by October. Brilliant as not brilliant as expected, sorry. It takes time to before he assimilates. This is making the father unhappy towards him. What can be done? I think sort of common issues, again, I'm not speaking from a clinical point of view, I'm speaking from just a general point of view. I think one of the struggles that you will know as, as a caregiver, as a mother or a father, is that sickle cell patients do have the times when they're faced with chronic pains or other discomforts that can get them to slow down in doing their schoolwork, as it were, and that in itself tends to pose challenges for caregivers if you're not patient with the process. So again, here my advice would be just be patient with the process. The child will come around, but give them as much support as is required. One asks, is sleeplessness more common among people with sickle cell? I can say yes, I've experienced it with my daughter. Again, from the clinical point of view, I cannot speak into why. I'm sure there's some scientific reasons to this, but yes, it is common. Again, engage the child, try to again sort of engage the child in terms of coming up with some structures, a sleeping structure that can help both you and the child, because I know, again, these are one of the areas as caregiver that affects not only the child but will affect you as well in terms of sleeplessness. And the last one, maybe if I can, is how well what can I do to reduce an infection in my warriors? Again, engage with the doctors and just make sure that they are on the appropriate medications, whether it's antibiotics, that at an early stage that will help reduce any infections. And this, I think, comes back to the issue of trying to make sure that you are attending to just the very basics about keeping the child free from infectious areas and, even things that will sort of bring about infections in the child. So I think, having said that, I'm so sorry I didn't manage to attend to all the questions, but having said that, again, from the caregiver point of view, there is a lot of work, there are lots of gaps, but there is so much progress that has been made. It's very promising. The horizon is looking very promising and encouraging, both for the sufferer as well as the caregiver. And I feel that as long as we keep advocating with sound and make the story of sickle cell louder, I think we are making progress, and there is a lot of things for us to do that we'll see that will break through with this condition. So thank you very much for giving me the opportunity to just share my story and just get the opportunity to answer some of these questions. Thank you.
Thank you. Thank you so much, Marjorie. I think you and maybe Biba as carers, I think we all share similar situations where, ASCA was born from that aspect where you needed support. Going to the hospital is becoming so hard and you needed support. I won't go too much into that. We are going to our last presenter for the evening. Daniel, you've been very patient. Sorry, we are running late. So please, Daniel, you can take it up. Thank you.
Hello, everybody. I'm going to try and be brief so I don't sort of drag the time any more than we need to. I think you and I first connected on LinkedIn, and then you came to London ASCA. So
you invited me to ASCA.
I did, and I was glad you came.
Thank you.
Yeah, it's what I would say is that, look, you're doing a good job. What you guys have achieved in such a short space of time, well, I kind of begin to explain that to you. Most people who have been around sickle for a long time would agree that sickle cell just gets shortchanged quite a fair bit, but you guys are doing a good job. So just carrying on with that momentum. I got sent a list of questions to answer, but if I can do something a little different for a moment. Now we're talking about psychosocial issues. Now, the psychological challenges, in my view, we're probably never going to be able to eradicate them completely. But what we can do is to definitely do whatever we can to minimize the impact on sickle cell patients. And for me, as a welfare worker, the key question that comes to my mind every single time is, anyone living with sickle cell, can they actually live well and achieve life goals? And for me, the answer is always yes. And I do know a lot of people who are doing big things, doctors, engineers, lawyers, accountants, you name it. And they are doing some really fantastic things, and they all live with sickle cell. Challenging, yes. But what every single one of them would tell you is that they didn't just get where they are without support. They have a whole network of people around them, nurses that they work with in the hospitals where they attend, the doctors at home, the families, siblings, a whole network of people that they have to rely on to ensure that they are where they are today. So I think that it is important, and I'm quite glad that every single speaker have kind of touched on the idea of support. So that is really, really important. And for me, looking at the wider issues of what we need to do as a community, I think that I want to touch on maybe 3 or 4 things. Again, a lot of them have been mentioned already. So education, it really needs to start from primary school. I think the last speaker, Marjorie, just mentioned on that. A young child who lives with sickle cell, they're going to be unwell a lot. So if the schools don't understand the condition that this child lives with and are prepared to make the necessary adjustments this child needs, then education is going to struggle right from day one. And so that we really have to try and work on that. The parents, I think you have to get into the mindset where you do not take no for an answer. If you think there's a problem, your child is falling behind in education, you just have to keep pushing the boundaries until the school authorities put plans in place to support your child adequately, because otherwise we are shortchanging that child already before they get into adulthood. I know we kind of running with time, so I won't go too deep into any of these. And then the hope is that when we support the child adequately, yeah, we're giving them the options where the sort of things that they are now studying can open up paths for career choices that they make as they grow up. So this is important because every single person that I know who is doing well, this really was the issue, that they had the support of family at home, they had the support in education, and then of course they were able to choose the right sort of career paths, which obviously is helping them well now they're adults. And so in terms of employment then, one of the challenges that people face with employment is that employers, again, don't tend to understand sickle cell very well. And so people who live with the condition get branded for being lazy, you know, just because people don't understand the condition that this person lives on a daily basis. But can they actually deliver the work? Yes, of course they can. But employers need to understand and make the necessary adjustments for them. Now, for the person who lives with the condition themselves, one of the things that they probably need to come to terms with and feel confident and comfortable talking about is the condition that they live with every day. Yeah, because you know, when you find yourself in a work environment, the employers don't know that you live with this condition, then the difficulty for the employer is that, well, how do they know they need to make adjustments for you if you haven't told them that you live with this condition and this is how it affects you, and this is the kind of adjustments that you might need. Simple things like maybe a portable heater. Okay, so in England is very cold a lot of the time. So a portable heater for the person living with the condition near their desk is usually a good trick just to keep them warm. Yeah. And again, if the employers don't know that you live with this condition that affects you in this way, they might actually go sit you by the window, which is never a good idea in the middle of winter. And maybe somebody sitting next to you is someone who, you know, needs a bit of breeze, and then that window is going to be open. So it really is important. I know it's not very easy for many people to be upfront and discuss this situation with their employers, but it is worth considering, because if they know from start, then you have the possibility of having you know, adjustments made for you. Okay. And another thing that a lot of people don't tend to think about is living conditions at home. Funny enough, you know, in the area where I work, we come across a lot of bad housing. You know, either the heating system is not working very well, or we have situations where there's a lot of mold, damp, and these things would trigger crisis a lot. You know, the sickle cell patient is going to be ill a lot, and they're going to end up in hospital a lot. Yeah. So if you have these kinds of situations, I think the first thing you really and truly want to do is to push. If you own the property, then of course you have to fix that problem. But if you're renting, then you really want to get on top of your landlords to try and fix these problems. Because, you know, as we know, for those of you who are familiar with sickle cell, you know that cold, damp, mold, it's just a big no-no. It's just a big no-no. So you have to watch out for these things. Now, there's been a mention of advocacy, and this is where it really is important that as a community, we ensure that the advocacy work that we do is absolutely intense, that, you know, everybody who needs to know about sickle cell and how some of these little challenges can be a big deal for a sickle cell patient, so they know. So that when we're advocating for somebody who lives with sickle cell in a bad housing conditions, then they understand that actually we're not just having them on. We are being serious, and, you know, long term, this person who lives in conditions like this would suffer. And, you know, so we definitely have to try and address those issues. And also, if for those of you who lives in parts of the world where there's a sort of a welfare benefit system, you really do have to push, because sickle just happens to be one of those conditions that nobody ever understands it unless you are within the community that lives with it or working around the sickle cell patients. So in the wider population, it becomes a really, really tough business to try and advocate for welfare support for people living with sickle cell. And we have to try and think of imaginative ways to present the information to the decision makers who are going to decide whether somebody gets a welfare support or not. So again, the advocacy would help, the education of the larger population would help, because, you know, and this actually needs to start with the community itself. Yeah, you know, I do appreciate that with sickle cell, people don't tend to have the energy, and so to expect them to come out on the street and help us advocate and put the message out there, it's a tough one. It really is a tough one. But it is still important that when we are out there knocking on doors, whether it's in, you know, corridors of power or not, it really is important that we have the community behind us to push this button, to push these powerful key, what was the word, stakeholders, you know, the real actors in the power corridors who can make the change. Yeah, because if they don't see the community come out and push, then as far as they're concerned, there is not a problem. Yeah, I think I'm probably gone past my time now. I can see Agnes on the screen. So really and truly, what I want to say is that the level of advocacy needs to be coming from the community as much as possible. And yeah, so what can we do to help the community? Education is important. Let's get it right from start. Healthcare is absolutely paramount. Healthcare professionals tend to misunderstand sickle a lot. Let's try and correct that. Employment, let's get on top of employers so they make the necessary adjustments. Housing, let's get it sorted. Welfare, if everything is in place, then I think we will continue to have sickle cell patients living well and achieving big things. So thank you very much.
Thank you so much, Daniel. So a very, very nice presentation. Naturally, I don't know whether we should dive into questions because some of the questions have been answered. Is there any burning questions that we can go through, or should we wrap it up because we are almost?
I think we probably should wrap it up. Thank you very much to the panelists. They did address a lot of the questions. They worked into their presentation, so that was fantastic. And I probably will segue into that. So for those who don't know me, I normally stay in the background, even though I am Agnes's slave driver as well. My name is Natalie Capuia, and I'm the board secretary of ASCA. I joined Agnes on this journey a few years ago, still going. And basically, I would like to say what a fantastic way to celebrate this day in Australia today. I am very impressed, and from there, as ASCA, I would definitely like to extend our gratitude to all our wonderful expert panelists for taking time to participate in this session and to share some really important and meaningful information while shedding light on SCD and its evolution. And at the same time, thank you to our patient representatives and caregivers who shared their experiences. It's not for nothing that these patient representatives are known as warriors. Thank you for talking about the importance of mental health and the impact of SCD on families, and maybe I'm biased, particularly on mothers. Education and understanding certainly go a long way in attenuating the emotional impact that any parent faced with this particular challenge faces. So I would definitely encourage anyone who is affected to educate themselves. It also equips them to be a better advocate for the person that they're caring for. And last but not least, thank you to our audience on Facebook and for everyone that took the time to join us tonight. And I would also like to add that I am cautiously optimistic that while things are still patchy, as Dr. Kalumba mentioned in his presentation, I'm heartened to hear physicians include quality of life as an important metric outcome, focusing on the psychological effects of SCD. I think that is very important. And last but not least, thank you, and let's all keep doing this important work. And happy World Sickle Cell Awareness Day to all of you who joined in.
Yeah. Well, thank you very much. I won't take anyone's time. If anybody wants to say anything, we are running late, but thank you so much for everybody who've come on this panel from all parts of the world. And yeah, we are a very young organization. Natalie and myself and a few others, we run around, but we put this through. Thank you so much for joining us. And yeah, that's all I can say. It's been a very good period. Thank you so much.
Yeah, well done to you. Well done, guys. Great work.
Thank you. Oh my God. Thank you. Thank you so much.
Good job, everyone.
Happy Sickle Cell Day, everyone.
Sickle Cell Day.
Sickle Cell Day.
Bye.
Yes.
Have a great night.
Zambia and the UK, it's your turn now. Canada, Biba, your turn. We are done.
Okay.
Bye.
Yes. Thank
Bye,
you.
everyone.
Thank you so much. Bye.
I'll see you soon, Biba.
Bye-bye.